My name is Mara Hickey. I am a board certified specialist in small animal emergency and critical care medicine. And for this segment, we're going to discuss emergency wound care, hemostasis, bandaging, and antimicrobial coverage for patients with traumatic injuries, with a special focus on looking at how to manage this in an austere environment. Now, when a patient comes in with traumatic wounds, basically any area of the body could potentially have wounds. And so we're going to kind of go through this location by location. So if a patient has been identified as having abdominal wounds and you have access to gloves, please put them on. Otherwise, please have clean hands if at all possible and use those to cover the open wound. Now, this could be any type of wound to the abdomen. It doesn't have to mean that you see evidence of penetration into the abdominal cavity, but we always want to presume that any wound in the abdominal region could have penetration. Now, if the patient has eviscerated organs outside of the peritoneal cavity, it is very important not to replace those organs. Instead, you just want to lavage everything with at least a half a liter of sterile fluid, whichever you have access to is fine. And then you want to cover the open wounds and any eviscerated organs with sterile dressings that are soaked in a sterile fluid. And then you apply an outer bandage over that. If there is any type of object penetrating the abdominal cavity, you're not going to remove it. You're just going to want to help stabilize it, usually with a bandage. Now, if these types of wounds are being identified in the field where you don't have access to much, or if you unfortunately are in austere circumstances where you don't have access to a large amount of fluids or bandaging materials, you can use any type of plastic. You could use a cling wrap as an outer dressing and have the inner dressings be paper towels or cloth, basically something that you can potentially get damp to help make sure that the tissues don't dry out, as well as then having that more protective outer coating. Now, if we have a patient with a thoracic wound, similar to abdominal wounds, we are always going to presume that there could be penetration into the thoracic cavity. And for wounds, especially if they seem to be sucking chest wounds, where you can see or hear the fact that there's air movement while the patient is breathing, you can apply an occlusive seal over it. In an ideal world, we would clip hair, but truthfully, most of the time when we are looking at doing this type of wound care out in the field, we don't bother to clip hair. Instead, we just make sure that we have some type of seal that can occlude over the opening so that we don't have any further air getting drawn into the pleural space. Other things to consider if you don't have an open wound, but the patient seems to be having progressive difficulty with their breathing, is they may be developing a pneumothorax. And so you might need to do needle decompression or even a finger thoracotomy and potentially intubate them to get control of the airway. Now, in an austere circumstance, you can still attempt to do an occlusive seal, which sometimes is something as simple as some plastic wrap and some type of lubricant or sticky paste used as an adhesive. But truthfully, if you have a patient who has severe chest wounds, you may be better if you have very limited resources to consider euthanizing the patient instead. Patients that have injuries to their skin, absolutely anywhere, and this can include abrasions, lacerations, and even chemical and thermal burn injuries, you generally are going to want to initially cover up the wounds with a sterile lubricant and bandage. And if you are able to get access to facilities early on, the sooner we can clip the hair coat and lavage with sterile fluid, cleaning the surrounding tissues and rebandaging, the better. The one thing you usually aren't going to have to worry about early on with these types of skin injuries is doing debridement. Surgical debridement usually is not indicated within the first day or two. We want to really have a chance to see just how much tissue is affected. And given that we know that anesthesia, as well as other things, can increase the risk of ongoing injury for these trauma patients, holding off on surgical debridement early on is appropriate. Now, if you do not have access to sterile fluids, if you don't have access to sterile lubricants, if you don't have access to sterile bandages, there are things that still can be done for skin wounds. Tap water works very, very well to help remove visible debris and to help keep the tissues moist. If there's a large amount of hair, you can consider trying to trim the hair right by the edges of the wounds with some bandage scissors. Don't bother and try and trim it all off. And if you really can't get the hair trimmed, that's not going to be a huge deal. And a lot of times we just want to try and cover over the wounds with some type of temporary bandage. So cloth of any sort can be used. You can then, if there's a high risk that the patient's going to soil the bandage, or if the environment is going to soil the bandage, you can always cover it then with some plastic wrap or cling film to try and help have a bigger protection along the outer edge of the wounds. Now, if the patient has injuries to their face, including their eyes, you would definitely want to consider flushing the area with sterile fluid if you have access, and placing an Elizabethan collar to keep them from traumatizing their eye or the other parts of their face that might be injured. And if there is any type of penetrating foreign body in the eye, you don't really want to remove it in the field. That is something that you're going to want to be in a more controlled environment to do so. We don't want to flush the eye if there is a penetrating ocular injury, not just because that could dislodge the foreign object, but also because that could lead to fluid making its way into the eye itself. And preventing self-trauma is also going to be important with placement of an e-collar. Similar to skin injuries, if you don't have access to sterile fluids for eye injuries, you can use tap water for flushing of the eye. And e-collars can be made out of so many different materials. I've seen it made out of buckets. If you have access to radiographic films, you can cut those up and make into a nice, flexible but strong Elizabethan collar. Cardboard can be effective. I've seen people use pool noodles to try and prevent the patients from being able to get to their face. So there's lots of potential options where you can kind of rig something together to have it be effective. Now, beyond cleaning out wounds themselves and covering them, we do also need to know what to do when those wounds are bleeding and not stopping. And we also need to make sure that we evaluate to see, could there be hemorrhage elsewhere that isn't initially visible to the naked eye? So massive hemorrhage is something that can occur when a patient's losing more than 15% of their circulating blood volume. And it can occur in any real space or any potential space. And so things that might happen is the patient might start to bleed into their pleural space or even into the parenchyma of their lungs, in which case you're going to see changes in their breathing. Bleeding into their abdominal cavity, you oftentimes will see abdominal distension if it's a large amount of hemorrhage that has occurred, but if it's a smaller amount, it might not be quite so obvious. You can definitely see long bone fractures for these patients, and we can see a lot of bleeding that goes along the fascial planes around there. And we can definitely see bleeding associated just with injury to large vessels. And in general, we tend to think of arterial bleeds versus venous bleeds leading to either spurting blood, which is a brighter red, or oozing blood, which is a dark red. But if you have a patient that has lacerated a very large vein, it's going to be a little bit challenging right off the bat for you to necessarily know if you're dealing with an arterial injury or a venous injury, because so much blood can come out of those vessels so quickly. So hemostasis is something that we want to try and do, and there's lots of different options for it. So external compression is definitely the mainstay for any type of external hemorrhage, any compressible hemorrhage that we can see. So that can include doing things like placing pressure bandages on any limbs that are bleeding. There are bandages out there that contain procoagulants in them. There are procoagulant powders and gels, all of which can potentially be put directly on the site of bleeding and then covered with another type of bandage. If you have the ability, you could ligate any large bleeding vessels, or if you have a portable electric cautery, you can cauterize the large bleeding vessels. And in some cases, if none of that works, you might need to consider doing a tourniquet. Now, tourniquets are not very helpful for proximal limbs, but can be used for distal limbs or tail injuries. But if you ever are placing a tourniquet on a patient, you absolutely need to make sure that you mark down the time that it is placed, because we can't leave tourniquets on for too long because of the fact that that is going to lead to complete ischemia of the limb distal to the location of the tourniquet. And while in the short term, that might not make a huge difference, in the long term, that might make a difference in terms of if the patient's not going to be able to function with only 3 limbs, then it might be better to consider euthanizing this type of patient early on rather than going through this whole process. With hemoabdomens, most of the time, a traumatic hemoabdomen does not require emergency surgery. If it is required, we oftentimes just do a damage control surgery. So we're just going in and getting out as quick as we can, just trying to clamp off and tie off whatever could be tied off that is bleeding, with a plan that when things are a little bit less hectic and when the patient is hopefully a little bit more stable, can go back in and clean up the mess that is probably still inside. So most of the time, if I have a patient show up with a hemoabdomen due to trauma, if they're not immediately responding to basic supportive care, which would be limited volume fluid therapy, things like that, then I would consider placing a belly wrap. So it's kind of equivalent to the shock trousers that we might see in human trauma patients. So we may be wrapping bandages going up both legs up to the abdominal cavity, or we may just wrap the abdominal cavity itself. But the idea is that we're increasing the pressure in the peritoneal space, which is going to actually help compress some of those bleeding blood vessels and bleeding solid organs in the abdominal cavity to try and achieve appropriate hemostasis. So, bandaging. Obviously, it's part of what we use to achieve hemostasis, and it's obviously what we use to try and help protect wounds from any ongoing injury or contamination. And we can also use bandages to stabilize any fractures or luxations that these patients might achieve thanks to their traumatic injuries. So there are some kind of rules of bandaging that we often think about. If we're using a bandage to try and stable a fracture or luxation, we must make sure that we can completely stabilize and immobilize the joint proximal to the injury site, as well as distal to the injured site, which means that if we've got a femur or a humerus, that's going to be much harder to be able to stabilize than if we have one of the more distal long bones being fractured or luxated. There's something that we think of as the pyramid for the bandage, which means that the innermost layer of the bandage should extend beyond the outermost layer by 1 to 2 centimeters. And the reason why we have that type of pyramid shape is that we want to not cause an accidental tourniquet. We don't want to cut off blood supply by having the most external layer actually overlap the internal layer, which can compress down and stop blood flow to the rest of the limb. When we're placing the bandage, you always want to start at the distal aspect of the location and work your way proximally. And if you are bandaging where it's going to include the distal portion of the leg, you want to make sure that you leave the middle 2 toes. If this is a 4 or 5-toed animal, and so that you can monitor those and see if there is development of swelling, which might indicate that there is a tourniquet developing from your bandage, or that the bandage overall is too tight, or that there's ongoing issues with that limb. And when possible, it's really important to try and label the bandage with the date and time of placement, especially when we're dealing with things like mass casualty events. If we're slapping bandages on patients right and left, it can be very, very easy to lose track of which patients need to have bandages replaced. And so by labeling them with time and date, that can ensure that the ongoing efforts to provide care for these injured patients are not going to end up leading to detrimental effects. So the layers of the bandage are 4. First off, for a bandage that is on a limb, we want to place tape stirrups. And these are there to prevent slipping. Now, obviously, if we're bandaging around a neck, that's really not going to be an issue. If we are bandaging a proximal portion of the limb, that's also not going to be very feasible either. But if you're going to be bandaging where it's going to include the distal half of a limb, tape stirrups are very important. Your inner layer might need to be adherent or non-adherent, and there are pros and cons to both. We tend to lean more towards wanting to do non-adherent if you have access to non-adherent dressings, but if all you have access to is something that you know is going to stick to that wound, it's better than not having a bandage on in this early stage. Middle layers of bandages are there basically to absorb any excessive fluid and to help with increasing pressure and compression on wounds, which can lead to improved pain relief for these patients. And then the final external layers can be compressive as well, and they often are made up of roll gauze and elastic wraps of some sort, and they both help keep the bandage in place on the limb or other site, as well as help protect the bandage and the limb from becoming soiled or any further injury. Now, in austere settings, you may not have access to much in the way of bandage material, and especially if you're doing some type of field triage and field treatment for mass casualty events, you are basically going to need to plan that whatever bandage you are placing is going to be quite temporary. So if you have access to medical tape, that is what works best for making stirrups for the underneath of the bandage. Any type of plastic-based tape is not going to adhere very well. And, you can do without stirrups if you need to. If our goal is primarily just to get wounds covered and or to try and just temporarily stabilize a fracture luxation, it's not going to be the end of the world if we don't have stirrups. So don't get too worried about that. Your inner layer, you can use any type of personal lubricant between the wound and the bandage to try and help prevent it from sticking to the wound site instead. We can use things like honey or a paste made out of sugar and water, or even something like petroleum jelly to help protect the wound. And honey, we know, has some antimicrobial properties, so it can potentially be beneficial. And then if you have access to traditional bandage materials, that's fantastic, but you might not. And so any type of clean cloth, or heck, even paper towels, could be used for that inner layer, just something that's going to help prevent things from rubbing anymore against the wounded site. Now, for the middle layer, which is to be an absorptive layer, probably the things that you might have access to in a more austere environment, if it's not traditional bandage material, would be cloth, stuffing from pillows and furniture and stuff like that. All in all, we recommend using cloth over those types of stuffings, just because some of the stuffings are more likely to either break down, clump, things that could lead to further injury and pain for the patient, whereas cloth is at least a little bit smoother, a little bit easier to layer in an appropriate fashion. And then your outer layer, you can use absolutely anything at all that is protective. If you have a boatload of medical tape, wrap that whole bandage up with tape. Just don't compress things down so much that there's no blood flow to the distal limb. If you have access to plastic wrap, cling wrap, something like that, that's great. If you don't have either of those, you can just put some more cloth on. And if you have a bandage that is on a distal limb, if there's any type of way to secure it to the patient, that is good. So if there's no stirrups, if you can at least have some tape going from the proximal part of the limb onto the proximal part of the bandage, that at least might help prevent it from slipping while you are transporting the patient. Now, external coaptation is what we're going to be using, again, if we have a patient who has a fracture luxation. And the ideal splint is going to be lightweight and non-malleable, meaning if the patient puts their weight on it, it's not going to buckle and bend. And obviously, there's lots of wonderful pre-made supplies for veterinary patients, spoon splints, lateral splints, all kinds of things like that. They also can be made out of casting material. And when you are placing a splint on a patient, if you have access to traditional splints and traditional bandaging material, you want to have it placed about midway between the roll gauze layers. So that's going to be just at that first part of the external layer when you're looking at the 3 layers of the bandaging material itself. In terms of where to place it on the limb, you want to place it along the long axis at either the lateral aspect of the limb or the caudal aspect of the limb. We don't want it to have it be medial or cranial, just because the way things tend to bend and give, it's going to be much more supportive in the lateral or caudal location. The other thing, if you are making one yourself out of cast material, or you're using a pre-made one, you don't want to use a splint that's going to cover really more than about 50% of the circumference of the limb. And some of that is because we just expect that the limb is going to have some swelling in that period of time following the injury. And if we have too much of the circumference of the limb basically confined by a splint, that can actually lead to a decrease of blood flow to the distal limb, and that's not going to be beneficial. Similar to the pyramid that we use for displacing regular bandage material, if we are placing a splint, we also want to make sure that the splint does not go substantially over either edge of the inner layers of the bandage, because we can have that splint then rub on the skin itself. And depending on how that last layer of bandage is placed with a splint in there, that could potentially compress down and lead to a tourniquet effect again. Now, in general medicine, if we don't have access to splints, we can use a Robert Jones bandage. So this is not the modified Robert Jones, which is small and relatively mobile. These are gigantic, big, thick bandages where you're using a huge amount of cast padding. So it's going to thump like a ripe melon if you thwack it with your finger. And it's pretty unwieldy for patients to move around in, but it does do a very good job of preventing basically any part of the limb that is under that bandage from being able to move. So that is something to consider. Now, if we are in an austere environment where you don't have access to these types of splint materials, you still want to follow the same recommendations that are made for first placing your general bandage. And then if we have to make a choice between trying to improvise a splint and trying to come up with enough material to make a Robert Jones bandage, I would strongly recommend improvising a splint. So we've got lots of options of what could be used for splint material. Basically, anything that is relatively lightweight and that isn't going to buckle can be used in the short term. So I am a fan of multiple layers of cardboard, especially if you have it where the lines of the cardboard are going in opposite directions, or at least a 90-degree tilt from the underlying layer. That provides a good amount of support. If you've got access to any relatively thin pieces of wood, a couple of layers of veneer, like from cabinets and things like that, could be helpful. Hard plastic can potentially be used. So I have seen people take the water bottles, empty them out, and squash them flat. I have seen people take materials from plastic windows, cut up portions of plastic buckets, and worst case scenario, get a stick. You can use a stick as a temporary splint to help make sure that you are stabilizing that luxated area or fractured area of the limb. And all of these bandages, again, if we're doing them temporary, the goal is that when we get to a location where there can be definitive care and hopefully access to better supplies, then those bandages and splints will be replaced after the wounds have been better evaluated. So the last thing to talk about is antimicrobial therapy, because in a variety of different circumstances, we may be quite limited in terms of what antimicrobials we have access to. And there actually are only a few indications for us to give antimicrobials to trauma patients. So the times when we would want to use an antimicrobial is if there's evidence of an open fracture. So the patient's got a definite fracture and there are open skin wounds in the location near the fracture. That is a patient who 100% should get started on antibiotics. If the patient has wounds that seem to be involving the joint capsule, either because you're seeing joint fluid dripping out or the joint capsule is wide open and staring you in the eye, then yes, that patient should be on antibiotics. And if the patient has severe wounds that are covering a large percentage of their body area and or has multiple penetrating wounds, then that is a patient who is likely to be appropriate to have antimicrobials. Whereas patients that have small wounds, their immune system should be fine. Patients that have closed fractures, don't need this. Patients that don't have their joints involved don't need to have antibiotics. Patients with just abrasions, patients that have burn injuries also do not need antimicrobials. And in general, we recommend starting with first generation cephalosporins, if you have access to those, as the initial antibiotic for these patients. We try not to go broad spectrum right off the bat for these types of wounds because, first of all, there may not be access to them. And second of all, we may need to save some of these broader spectrum antimicrobials for human patients, but also because just good antimicrobial stewardship indicates that we use the simplest antimicrobial that should be effective against the majority of the bacteria that could lead to contamination. So that is the basics for what you need to know about dealing with these types of traumatic injuries: wound care, hemostasis, bandaging, and antimicrobial therapy for our trauma patients.